Okay, welcome everybody. Welcome to our bronchiectasis question time webinar, which today is focusing on how to take control of your bronchiectasis. And we hope you will get lots of useful information to take away with you today. I am Jeanette Boyd and I work for the European Lung Foundation in their patient involvement and engagement team. And I work very closely with our bronchiectasis patient advisory group, who have been involved in planning this event, and two members of our group are taking part today. And this webinar is just one in a series of events taking place around the world for World Bronchiectasis Day, and I'll mention a bit more about this later. But first of all, there's some housekeeping information to tell you. So we have translation available today, and you can access automated translation in over 60 languages. And the link to the Wordly app is on screen and it'll be in the chat, and you can also scan the QR code. And when you access the app, select the language you want from the drop-down menu and click Attend. And Wordly will open in a screen, and you can position this screen alongside the webinar to view both screens together. You can read the transcript on your device, or you can use a headset to listen to the audio. We know that automated translation won't be perfect, but we hope it will help you follow the conversation today. But if you have any problems accessing the app, do email info@europeanlung.org and a member of the ELF team will help you. Now, this event is a webinar, so you can only see the hosts and panelists. We can't see you as participants, and everyone is on mute, so we can't hear you either. And we will be answering questions that have been submitted in advance to our panel of experts, who we will meet in a moment. And we also have an expert answering questions in the Q&A box. So do put your questions in there during the event if you have any. And if we don't have time to answer all the questions today, we will try to get answers from the experts after the event and put these on our website. And please remember, we can't answer questions about anyone's personal circumstances or case. And the webinar is being recorded and it'll be made available on the ELF website in a few days. And we'll send a link in an email to everyone who registered so that you know when it will be available. Now, as most of you will know, today, the 1st of July, is World Bronchiectasis Day. And this is a day that aims to raise awareness, to share knowledge and discuss ways to reduce the burden of bronchiectasis for people living with this disease and their families. And you can visit the website of the COPD Foundation in the US to access more information, resources, and to see other events that you might be interested in. The European Lung Foundation and Embark are partners in this global coalition. And we do have an international audience, I can see today from the chat. And so we do hope this will bring new knowledge to everyone attending. If you use social media, then do get involved using the hashtag World Bronchiectasis Day 2025. And you can see the handles of organisations to tag on the screen. And finally, before we get going, we have some exciting news in that we have launched a survey this week to help us understand more about the full impact of bronchiectasis on people's lives. And we want to hear from you about your experiences in areas that are often overlooked in research and care. So these are topics such as gut health, fertility for both male and female, the menopause, other health conditions that you experience, the medication you use, and the use of herbal and complementary therapies. So please do complete the survey and help us uncover your untold stories of bronchiectasis. And if you can promote the survey across your networks and contacts, please do. The survey has been co-developed by members of the Bronchiectasis Patient Advisory Group and researchers in Embark. You can fill it in anonymously and skip any sections you don't want to complete. And it's also available in 8 languages. So do fill it in. There's a QR code on screen and a link will also be put in the chat. So I think it's time that we get started. So I'd like to hand over to our question host for today, who is Bridget Harris. So over to you, Bridget.
Thank you, Jeanette, and welcome to everybody joining us today. Thank you to everyone who sent in questions. We've had a lot of interest in this bronchiectasis question time, so I hope you find it useful. My name's Bridget, I live in Edinburgh, and I've had bronchiectasis for a number of years, although diagnosis took some time, which is not uncommon. Today's webinar is focused on bronchiectasis in adults. We did receive some questions relating to children with bronchiectasis, and these are important, even though they're not the focus of today's event. So we wanted to signpost anyone wanting more information on childhood bronchiectasis to a recording of the question time webinar from last year that focused on childhood bronchiectasis. And the link to the recording will be in the chat. And also the website of the European Research Network called Child BearNet, which includes some patient resources. And again, the website will be in the chat. And just in case anyone isn't sure, bronchiectasis is a condition defined by abnormally wide, damaged and distorted airways in the lungs, which are prone to infection. In many cases, but not all, it means we produce excessive mucus, which is hard to clear. We have to get rid of the mucus using airway clearance exercises to reduce the risk of flare-ups of infection. And it's a varied disease that has different causes, some unknown, and can show itself in different ways. So not everything covered today will necessarily relate to your particular circumstances, but we hope that much of it will. And as Jeanette said, we can't answer questions relating to individual cases, but for today's webinar, we've classified the questions that were submitted into different themes. And as well as listening to the answers from our panel, you can put written questions in the Q&A box, which will be answered by our expert behind the scenes. And now I'm going to ask our panel of experts to introduce themselves. Rachel, would you like to start?
Hi, I'm Rachel. So I'm part of the patient advisory group along with Bridget, European Lung Foundation. So I'm a writer and a translator. I'm based between Portugal and the UK, so I have experience of treatment in both of those countries. And I've had bronchiectasis for probably about 15 years, and I was diagnosed about 4 years ago. So as Bridget said before, this is quite a common situation.
And Arietta?
Hi everyone, I'm Arietta Spinu. I'm based in the UK and I'm a respiratory physiotherapist in the background.
And Raja?
Hi, my name is Raja Dhar. I'm a pulmonologist who works in India and I lead the Bronchiectasis India registry. An absolute pleasure to be here with all of you on World Bronchiectasis Day.
And Mikhail?
Hello, my name is Michal Steinberg. I'm a pulmonologist from Haifa, Israel. I focus my work on bronchiectasis and also CF and non-tuberculous mycobacteria. And I'm a proud member of Embark project and also coordinating the Embark activities with patient engagement and education. Also very delighted to be here today.
And the person answering your written Q&A behind the scenes is Peter. Peter, do you want to introduce yourself?
Hello, I'm Peter Humena from Belgium, a respiratory physician. Like Raja, I'm not only here for the gender balance, but also here to answer your questions. No mucus plug to stick in, no question to obscure. Think of me as the cilia trying to keep this chat clear and moving.
Thank you. And now, without any more delay, I'm going to ask our first question. And the first theme is symptoms and exacerbations. And the first question is, what might have caused my bronchiectasis? And I think, Amelia, you're going to start with that one.
Hi, thank you. Yeah, so I'm Amelia. I'm a scientist doing translational research in bronchiectasis. And the question, what might have caused my bronchiectasis? So as Bridget said at the beginning, bronchiectasis is the condition of the scarring of the lungs along with symptoms, but it has many different causes. In about 40% of people, we don't know what the cause is, and research is important to identify that. But about 60% of people, we do know what the cause is, and it can be due to a bad infection, it can be due to problems with the immune system, or it can be due to inherited conditions that have been present since birth. So it's an important question to ask your doctor whether they know what has caused your bronchiectasis, because there's tests that can be done to try and identify that. They might not always identify something, but there are tests that can be done to try and identify that. And sometimes if you know the cause, it can change the way that your bronchiectasis is treated and the way that you're managed. So it's an important question to ask.
Thank you, Amelia. And I'm sorry I left you out of the introductory by mistake. Right, the next question. People have asked, what other questions should I ask my doctor about my condition? And in relation to that also, how can I get my doctor to take my bronchiectasis and my symptoms seriously? And I think, Rachel, you're going to start with that.
Yeah, it's difficult. Bronchiectasis is a condition that is not really that well understood by a lot of medical professionals. And I think from the work that we've done with the patient advisory group, we just see that it's very variable. People's experience is very variable. You could go to your GP, or what that would be in the UK, your first contact practitioner, and they could know all about it and have lots of ideas, or they could really not really have heard of it. You could also go to a pulmonologist who doesn't know anything about it, or you could go to one who does. The ideal is to try and get a bronchiectasis specialist. But if you can't do that, there's no need to panic, I think. You know, systems are different. There's lots and lots of information online. So I think my experience was that I just couldn't get care at first and nobody knew. And I was given asthma inhalers repeatedly and they didn't work. And I knew that I didn't have asthma. But it wasn't a question. I couldn't find somebody who knew. So I just went online and read everything I could. Obviously, you have to be careful when you go online. Don't just go on Facebook and Google, you know. Be careful about the sources that you use. And I think we'll put some links in the chat of useful sources. And the European Lung Foundation has loads of sources. So you can educate yourself. You can try and find out what is known out there. Also be aware that there are things that are just not known by anybody yet that might be being researched. There are things that will be individual to your circumstance, and there just aren't enough people with bronchiectasis who have been part of research for clinicians to necessarily know about everything. So there are some grey areas, there are some unknown things, there are some ways you might respond or not respond to treatment that only you will find out when it happens. So you can inform yourself as much as you can. And I would say really concentrate on the relationship you have with your doctors. So don't think about what they do or don't know, just think about whether they listen to you, whether you can talk to them, whether they give you enough time. If they don't give you enough time, ask for it and say, look, I want to say a bit more. I want to ask a bit more. And tell them everything you can think of. All other health conditions, any other things you experience, just tell them everything in your head if you can, even if they don't ask. So there are lots of other things that I have going on in my body that I think are connected. When I say it to my doctors, they don't necessarily know why or if, but it helps them. It is useful. It helps them know what other tests to do. So try and talk as much as you can, try and research as much as you can is what I would say.
Thank you.
Just jumping in with online resources, there's the bronchiectasis patient checklist, which has been developed between the European Lung Foundation and EMBARC and other societies. And that's a list of 12 things that you could ask your doctor or discuss with your healthcare team. Essentially the basics that as a patient with bronchiectasis, you should expect to have the answers to, and that includes things like I suffer from breathlessness. I've discussed with my doctor or nurse whether I need to take an inhaler, or I've been shown exercises and airway clearance techniques to help me cough up sputum. So there's a list of 12 things, and I think someone has just put it in the chat. I think that's a useful resource for knowing how to start those conversations with your doctor, and basic education and information that you should be able to have.
Thank you very much. And then the next question, somebody has asked, can you explain what dry bronchiectasis is and whether the treatment is the same as for regular bronchiectasis? And Arietta, would you like to start on that one?
Yes, thank you. So usually we connect bronchiectasis with wet cough and lots of secretions, but there are some cases where people find that they have what we call dry cough, and that means that they present cough without bringing up any phlegm. I think the most important thing on this question is to identify if this is a truly dry cough that you have, or if you have difficulties to actually bring up the phlegm. So I would advise, if you have access to a respiratory physiotherapist who can support you with airway clearance techniques, that you check with them and you make sure that you have the optimal airway clearance technique for you first, and then confirm if this is indeed something that cannot bring up any phlegm, because we do see sometimes people who struggle to bring up the phlegm, so they think that their cough is dry, but when you actually perform the technique properly, then it's when they can expectorate their phlegm. So this is the most important aspect from the physiotherapy point of view, but I think Raja has some comments about the physiology behind the dry cough.
Yeah, so I think you heard from Arietta as to what you do when you have bronchiectasis, which is associated with less sputum, or sputum on a daily basis does not happen. If you think about the cause of your bronchiectasis, what caused the bronchiectasis in the first place, there are certain causes, mainly post-infection, which causes the bronchiectasis to be dry with less of sputum production. So when we looked at our Indian cohort of patients with bronchiectasis, we found there were two causes which caused less sputum production or no sputum production. One of them was post-TB. So as you know, India is a country which is endemic in TB. There's lots of other countries, South Africa, for instance, other Asian countries, for instance, where there's a lot of TB. Post-TB, the scars in the lung result in formation of bronchiectasis. However, these scars are mainly in the upper part of the lung. Because they are in the upper part, Arietta would tell you that physiotherapy to drain the chest, especially in the upper part, becomes more difficult. Hence, sputum production was less or low in patients with post-TB bronchiectasis when we looked at the Indian cohort. There's another disease which now is fungus related, the fungus being called Aspergillus, which has the name acronym ABPA. So that's allergic response to Aspergillus, or allergic bronchopulmonary aspergillosis, which is the immune system, your immune system response to the fungus, which is Aspergillus. Now, this fungus is found within the mucus within your breathing passage. This results in redness and swelling of the breathing passage, what in medical parlance is termed as inflammation. And this results in thick, viscid mucus, which blocks up the breathing passage. This mucus clearance is difficult in patients with this fungal disorder, which is called ABPA. The mucus is thick. The fungus gets trapped within the debris within the passage, and hence to clear the chest, you need physiotherapists, rehabilitation experts like Arietta, and it takes a lot to get this sputum up. So this is another reason of dry bronchiectasis, where sputum, there's other causes too, but these are ones which came up in the Indian registry. About 6 out of 10 patients in the Indian registry had dry bronchiectasis, which has just been described. And these are the reasons as to why you could get dry bronchiectasis.
Yeah, just a final point. If you indeed have dry bronchiectasis, I would suggest that you make sure you hydrate properly, you avoid caffeine or other alcoholic drinks, and you generally have a good vocal cord hygiene that can support you with the dry cough side.
Thank you. Our next question is, what are the warning symptoms of an exacerbation of bronchiectasis? And Mikhail, you're going to say something about that.
Yes, so this is a great question. And we know that bronchiectasis has day-to-day symptoms. And we also know that there's good days and bad days, there's waxing and waning of the symptoms. An exacerbation is defined as an increase in several of these symptoms over 2 or more days. And these symptoms that worsen may be more sputum, increase in sputum mucoidity, which means the color of the sputum or the thickness of the sputum. Sometimes there's a little streaks of blood in your sputum. And often people feel very tired, like when you have the flu and you just want to stay in bed all day. Sometimes there's fever, just not necessarily. A lot of people have exacerbations without fever, or there's just low-grade fever. So these are warning signs. What causes bronchiectasis? We don't always know. We know there's more inflammation in the airways. We think that there's an increase in the activity of the bacteria, which are always in your airway. So not a new infection, but the old infection getting worse. And we treat with antibiotics for usually 10 to 14 days of antibiotics. So it's quite difficult to understand exacerbations and to recognize exacerbations. But I think people, one of the key things to get control of your bronchiectasis is to understand what an exacerbation is for you and to keep record of what has helped you in the past. Usually, an antibiotic which has helped you in the past will probably help you also in the future because the infection is chronic.
Thank you. And Raja, would you like to say something about what we should do if we cough up blood?
Sure, Bridget. So I think that's a nice sequel to the question that Mikhail just answered, which is about exacerbation. So one of the ways in which your disease could get worse is if you start coughing up blood. Now, how important the bleeding is, how life-threatening it is, how urgent it is, depends on the amount of blood that you cough up. So I've just been drinking from this little paper cup, which has coffee in it. That's about 100 ml. So if you manage to cough up 100 ml of blood within a short span of time, or a large bout of bleeding at one go, you can have a clot which closes up your breathing passage. And that becomes a life-threatening emergency. So if you have bleeding, which is large enough to cause an obstruction in the main breathing passage, it is important to try and get hold of an emergency, get hold of an ambulance, and get to the doctor as early as possible. This does not happen commonly, but if you think about complications of bronchiectasis, this is the most important, the most life-threatening of emergencies that you can have. So it's not important to worry about it, but it's something to know about, because that's one indication in bronchiectasis where you need to get to a doctor or to an emergency as soon as possible. Now think about bleeding, which is less. Suppose you're getting small amounts of bleeding or moderate amounts of bleeding, which might be teaspoonful worth of bleeding. You need urgent medical attention even then, but that's not a medical emergency. You need to get hold of your doctor as soon as possible. Look for the color of the blood. If you see that the color of the blood is going dark or blackish, you know it's old blood that you're coughing up, and that's less of an emergency, that's less worrisome. Not that it negates the indication of going to a doctor, you still need to do that, but it's important to look at the color of the blood. When you have a cough and you're coughing up blood, it's important to rest. The more you try and walk around, the more you try and run around, maybe in anxiety and panic, there's movement within the body, there's movement within the lungs, and the risk of bleeding actually goes up in that case. Important to document the amount of blood. You've now got the era of smartphones, so take a photograph. Make sure that the doctor, when you get to the doctor at the emergency, knows the amount of blood that you've managed to cough up. Now come to the very small amount of bleeding. This is not uncommon in people with bronchiectasis. You get this sometimes. you should let your doctor know this has happened. This might be the flare of or an exacerbation, the way Mikhail described it. You might get prescribed a course of antibiotics. You might need airway clearance, which Ariata spoke about, but you need to be cautious, and I'm sure we'll come back to that topic later on. So I think you need to compartmentalize the amount of bleeding and react accordingly, depending on the amount of blood that you've coughed up.
Thank you. And Arietta, do you want to talk about airway clearance if I cough up blood? Somebody asked, should they stop if that happens?
Yeah, this needs to be assessed in a case-by-case mode. But in generally, what we do when we see blood in the phlegm is that we try to avoid something that is quite forceful or provides positive expiratory pressure. So lots of patients use devices that give them some positive pressure during the expiration. So if you see blood, it's better to leave this device on the side until you have resolved the case of the hemoptysis. So in this case, if you do need to continue your airway clearance because you bring up lots of phlegm, usually you try to switch into a technique which is more gentle, such as the active cycle of breathing technique. Or if you find that this is a more serious case where you have more blood, like Raja explained a minute before, then you need to stop and get advice from your doctor. So it's a little bit of a balance between the risk of retention of the secretions you have and making sure that the techniques are safe. But as a general rule, you avoid the positive expiratory pressure and devices in this case.
Thank you. Right, the next section is about monitoring my bronchiectasis and a bit more on airway clearance. And there's a question on how often should lung function tests be done? And Mikhail, do you want to say something about that?
Yeah, so when we speak about lung function tests, the most common lung function test we do is spirometry. And this is a procedure where the technician asks you to take in air and breathe it out as hard and as fast as you can for at least 6 minutes. And this gives us, it's a very simple test, but it gives us a lot of information. It gives us an idea about the air that you have in your lungs and is free to take out. And there's also a very important measure of how much air you blow out in the first second of expiration. So usually we recommend to do this test when we first diagnose bronchiectasis and to repeat it at least yearly. And what this test does, it gives us an idea about the function of our lungs. So the lower the forced expiratory flow in 1 second, or FEV1, this is the most useful measurement that we have in spirometry. The lower the FEV1 in percentage, the worse your lung function is. So a normal lung function is between 80% to 120%, and it's in percentages of what is expected from each person. And the lower you go, the more severe your lung impairment is. So, and there's a lot of correlations that were found between the lung function and how bad your symptoms are, hospitalizations and so on. So this test is repeated yearly. Some people do it during exacerbations, but unlike other diseases, in bronchiectasis, it doesn't always reflect how bad your exacerbation is. So you can have an exacerbation, but your lung function is the same as it has been. But it's a useful test mostly to determine how severe your lung impairment is.
Thank you. And would you like to also talk about how often a sputum specimen should be given and the use of CT scans to monitor bronchiectasis? Somebody asked if they can actually ask for a CT scan, but their doctor was a bit reluctant because they'd had quite a few.
Yeah. So I'll start with sputum because there's more agreement between us doctors about how frequently we do sputum. So we check sputum to see which bacteria we have in our lungs, our patients have in their lungs. And we test the sputum for bacteria. There's a lot more things in there, like viruses and fungi, like Raja has explained. But usually the most useful things that we can test in sputum is the bacteria. We do it at least once a year. We also do it at the start of an exacerbation because not always, but sometimes we do detect new infection during an exacerbation. So this is regarding sputum samples. Regarding a CT scan, we do it at diagnosis. We know we first diagnose bronchiectasis through a CT scan. What we look for in the CT is the dilated bronchi. But there's not really much evidence, or there's not much scientific findings that say that we need to repeat the CT every certain amount of time. Personally, I do a CT scan when someone is deteriorating and I don't find the reason. And I look for parts of the lung that are not aerated, that may be stuck, mucus stuck in parts of the lung, or other complications. But there isn't really a guidance on how often we should repeat the CT scan. So your physician may be right in that there is no reason to do a test if it's not going to change the way we treat. CT scanning, there's very, very little radiation associated with CT scans nowadays, but it's not negligible, it's not nothing. So we do need to think about why we do this this test.
Thank you. And the next question is, somebody wants to know more about which infections are most important to know about if you have bronchiectasis. And Raja, would you like to answer that one?
Thanks, Bridget. So again, almost a follow-up question to the one which Mikhail has just answered. So if you're doing a sputum test, you would want to know which bugs. And the first thing to remember is the bugs that you have would depend on which part of the world that you come from. So there are certain bugs which are peculiar to the country that you live in or the continent that you live in, and is going to be variable. So we'll touch on few which are common across the board, and then one or two which might be peculiar to the country that you hail from. So the one which is there globally, across the globe, the most common bug is something called Pseudomonas aeruginosa, which is a gram-negative bug. And those of you listening to us who have bronchiectasis or have family members with bronchiectasis would have heard of this bug called Pseudomonas. Why is it important? It's important because this is a bug which causes recurrent infection. It causes worsening of your bronchiectasis and exacerbations, and in a lot of cases actually results in greater mortality, more deaths from bronchiectasis. So what's important here is to try and treat this when you get an infection, but even more importantly, try and get rid of this bug. Often what this does in patients with bronchiectasis is that it makes your breathing passage in your lung its home. So hence you have long-term antibiotics, often antibiotics by the inhaled route, nebulized antibiotics in trying to get rid of this infection. And then people like Arietta with chest physiotherapy, mucus clearance also helps in trying and get rid of the excess mucus and hence getting rid of the bug along with these long-term antibiotics. So that's one bit about a bug which is important. I'll mention a couple of bugs which are less common from where I hail from, so from India, but very common in the West. Bugs like Haemophilus influenzae, Moraxella catarrhalis. These are milder bugs. They're bacteria which are milder. These bugs do result in a little bit of a flare-up of the disease, but don't result in as much of symptoms or as much of decline of lung function as the Pseudomonas does. These are treated with standard antibiotics. They're mainly oral antibiotics and don't translate into hospital admissions or severe exacerbations in most cases. So that's about the Haemophilus influenzae and the Moraxella. Let me then come to a bug which is very common in the US, somewhat commoner in Europe, but not so common where I hail from, so from India, and that's non-tuberculous mycobacteria. So non-tuberculous mycobacteria is a bug which is similar to TB, which has a lot of which is there in India. It's serious because, like Pseudomonas, it can cause progressive damage of your lung, and it can mimic an exacerbation. It can result in something which looks like an exacerbation. And like Mikhail said, this is the time when you need to get a sputum culture done. And maybe if the symptoms are persistent severe, this is the time when you would want to get a CT of your chest done if the flare-up happens and continues for some time. And this requires long-term antibiotics. Often these antibiotics continue for 2 years or beyond in trying to get rid of the bug. Another bug, which is more common in Europe, where most of you are from, is Staphylococcus aureus. And within this, you have the resistant Staphylococcus, which is called MRSA. And again, a lot of you would have heard of MRSA. This is a dangerous bug. It's difficult to get rid of it. It causes worsening of symptoms, happens more in younger people, and those who have more of cysts within the lung. MRSA seems more common in these individuals. So aside from these bacteria, it's important to think about viruses. We have been through the COVID pandemic, and flu, respiratory syncytial virus, COVID-19, etc., do trigger minor flare-ups, but more importantly, make the lung vulnerable to bacterial infection. So you get a viral infection, you get a bacterial infection on top, and hence this results in a severe exacerbation. And I spoke briefly about fungi. I spoke about Aspergillus. That's again an infection which is more common in Asia, more common in India, not so common in the West. But I think that's more or less a broad outline of infections that can happen in patients with bronchiectasis.
Thank you. And Arietta, would you like to talk a bit more about airway clearance? We have covered it a bit, but there are questions on when people should do airway clearance and when they should see a chest physiotherapist.
Yes, absolutely. And I think that's it's a key issue in bronchiectasis, isn't it? Because we have the symptom of sputum and phlegm. So first of all, when you get the diagnosis of bronchiectasis, ideally you need to be assessed by a respiratory physiotherapist. So you need to be taught of an airway clearance technique for sure. And some people might need to use this airway clearance technique daily or even a few times during the day, depending on how much phlegm they have and how much they can bring up. And some of them might need to use it only when they have a chest infection. So they get unwell and they find they have a bit more phlegm, and then they can use it. So it depends a little bit on the severity of the condition. But in general, you should be seen by a physiotherapist who is initially assessing you. And going back to your previous question, Bridget, so when you're getting your diagnosis, first of all, and then you need to be reviewed in a few months' time and check if you use this technique properly and what kind of adjustments you need to do. Because sometimes if we give a technique to someone who has an issue and they are not happy after using it for a while to continue with it, there's no point of insisting. And there's a series of different techniques, so we can actually try and see what's fitting in your own schedule, what is best for you, what you find more comfortable, or what makes you bring more phlegm up, and use that instead of trying to use something that doesn't work and quitting after a while. So definitely something when you're seeing someone for first time, and then review that, make any changes. So you might even need to go to a completely different thing after a while, or if your condition progresses and you need something more powerful, then you might switch then and escalate your treatment based on that. So there are different techniques that they don't use any equipment. There's also devices you can use. And I know it does vary a lot based on where you come from, and different countries have their own preferences, and physiotherapists use mainly one of these techniques or these devices. But the most important thing to remember is that we know from the evidence that any of these techniques is actually better than coughing alone, spontaneous cough, or doing nothing. So an airway clearance technique that you perform properly is helping you to clear your chest compared to not doing any airway clearance techniques. And we have a good understanding on that. When it comes to comparison between the techniques, we don't have clear guidance. So we haven't found that one of them is more beneficial over another one. So the suggestion now is clinically really identify what fits best to the individual.
Thank you. And Rachel, do you want to talk about your experience with physiotherapy? Because you've had quite an interesting time.
Yeah, I mean, when I first had my bronchiectasis diagnosed, there was no mention at all of physiotherapy. So for a long time, I just didn't know that that was part of the treatment for the disease. I would just assume there was not really any treatment. And then when I just started researching myself, I found out that this is what's suggested, but I couldn't see a physiotherapist. And I think a lot of people may be in a position where maybe they're on a waiting list, or maybe their doctor hasn't suggested it, or maybe they just can't see someone. There isn't someone available. So I went online and I found different techniques and I tried them, and it was an absolute game changer for me. So because I do my airway clearance every day, which is a very, very simple one, what I do is autogenic drainage. I modify it a little bit because I use some postures that I find work for my particular, where the problems are in my lungs. So I've tried out different things, but it's very simple. It doesn't take me very long. If I do it every single day, I have no symptoms. My bronchiectasis is asymptomatic if I do my airway clearance. And my bronchiectasis, in terms of CT, in terms of lung lobes affected, in terms of the bugs that I have in my lungs, is not mild, actually. It's on paper, it's fairly medium to severe, actually. But in my day-to-day life, because of airway clearance, my day-to-day life is normal. So I would say it's absolutely the most important thing. Just do anything you can. If you can't see a professional, wait till you can see one, do something, find some information.
Yeah, that's great to hear, Rachel. And actually, I fully agree. If you haven't got the access to a physiotherapist, try to find from the internet, from resources that you can trust, some of the techniques until you get access to that. And also, we do see that people can manage much better with airway clearance techniques in their day-to-day life. So it's about trying to stick with this treatment that fits to you, and you can have less cough during the day. You can feel less uncomfortable in terms of your chest and so on. And we know from studies that people who feel the benefit, as though they are those who adhere best with the treatment. So it's until you find this benefit and you can see the difference for you that you can actually follow it more.
And you do have to learn to just listen to what your body's telling you. So I have had to learn that there's certain times of day when it won't work for me, and there are other times that it will work. And exercise is very, very helpful for me.
Thank you. Just as a sort of add-on to that, there's a question about, are there things I can do to make mucus easier to clear? And Arietta, you might like to say something about that. And I think Mikhail also might say something about hypertonic saline in airway clearance. So Arietta, do you want to add anything on making mucus easier to clear?
Yes, absolutely. And so when you see that your phlegm is sticky and it's hard to sift higher, and we do know that in terms of triggering a spontaneous cough, the phlegm needs to be quite high in our airways, otherwise we're not going to cough it up. So if you find that this is quite sticky and difficult to shift, then it's a problem probably of the viscosity, so how sticky it is. And what you do is you make sure you are hydrated first of all, so you need to drink water. And if you need to escalate that, you can use hypertonic saline or normal saline, and you can make a trial with your physiotherapist in terms of the safety of using that, and then you can use it before you do your airway clearance to prepare the secretions and make it thinner and easier to shift, and then you do your airway clearance technique. But Mikhail, what would you like to say on that?
Yeah, first of all, I would like to really thank Rachel for bringing that up, because I feel the same way. I think about 60–70% of my patients do very well just with airway clearance, and they don't need anything else. I think most patients would have it. It's the safest, most effective treatment. I really also recommend hypertonic saline a lot to my patients because it thins the secretions and it makes airway clearance much easier. It does take time, which is a drawback, and it needs learning and it needs expertise. So it's much easier to take a pill than to do airway clearance. It's much quicker, but airway clearance is safer, it's more effective, and I think this is the key point.
Thank you. And now we're going to move on to treatment. And the first question is, why do people with bronchiectasis not get treated with antibiotics all the time? And Raja, that's one for you, I believe.
So I think when you think about antibiotics in bronchiectasis, you think of it in two perspectives. We've all said since the beginning of this session that the major problem, the major challenge with bronchiectasis is the infections. And you would treat infections with antibiotics. You've just heard Arietta and Mikhail talk about how important it is to do airway clearance, because if you do your airway clearance well, you would not need multiple courses of antibiotics because you would not get so many exacerbations. So that's, I think, a very, very important carry-home message. The solution is not just giving an antibiotic when you have a flare-up. The solution is doing your airway clearance technique, your mucus clearance regularly, so that you do not end up getting recurrent course of antibiotics. If you needed antibiotics, you would depend on a sputum culture, you would try and grow a bug, and you would give antibiotics accordingly. The problem with having recurrent bouts of antibiotics, recurrent course of antibiotics, is that it raises concerns about antibiotic resistance. It reduces the effectiveness of the antibiotic that you take if you use it on a recurrent basis, and hence it becomes more and more difficult for you to get rid of the infection that you have. That's why antibiotics need to be used prudently. It needs to be used judiciously. Now, aside from antibiotic resistance and treatment failure, there's also the chance of getting an adverse effect from having multiple courses of antibiotics. So the antibiotics often have gastrointestinal side effects. So you could have nausea, you could have vomiting, diarrhea, you could have liver problems, and there's a multitude of other side effects that you would worry about if you needed to take antibiotics on a regular basis. So of course, if you get an infection, you need antibiotics, but other measures like the ones that's been discussed need to be adopted to try and prevent infections. So that's one aspect and the side effects of antibiotics. The other area where you would think of using antibiotics is drugs which are called macrolides. So a drug that a lot of you would have heard of, maybe taken if you have the disease, is called azithromycin. And use of azithromycin at a lower dose, 3 times a week, on a long-term basis, has been shown to be the most effective drug we have in preventing recurrent worsening, recurrent flare-ups, recurrent exacerbations of bronchiectasis. You need to be cautious about side effects of azithromycin too. That happens in a small percentage of people. But normally, of all the drugs that we have till date, azithromycin or macrolides seem to be the most effective in preventing recurrent infections, recurrent exacerbations of bronchiectasis. And that's the other way for use of antibiotics that we all need to remember.
Thank you. And there's a question on inflammation. Since bronchiectasis is associated with chronic inflammation, somebody asked if it would make sense to administer anti-inflammatory medicine by inhalation. And Raja and Mikhail, do you want to talk about that?
So I'll start off. So we spoke about redness, swelling within the breathing passage, which Bridget has described as inflammation. So the inflammation can be of different types. So in asthma, often we get an inflammation which is predominant in a cell which is called eosinophils. Again, a lot of you would have heard of this cell. This results in the redness and swelling within the breathing passage. And if you have an airway where there's a lot of eosinophils, the most potent anti-inflammatory agent we have, something which quells or reduces inflammation, is steroids. So inhaled steroids can be the most effective agents in people who have a eosinophilic airway. Now, I spoke about asthma. A small proportion of people, maybe 1 out of 5 people with bronchiectasis, also have a breathing passage which can be eosinophilic. And hence, in the small minority of people, using an inhaled steroid might reduce inflammation in that population. Why am I being so persistent about 1 in 5 rather than a lot of people? Because here, the steroid might be a double-edged sword. If you give it to people who are getting recurrent infections, and if they all go on inhaled steroids, you might increase the number of infections these people get. And hence, it's important to select, it's important for your doctor to select the patient who's right for the inhaled steroid when you think about prescribing them. There's also inhaled bronchodilators, drugs which open up your breathing passage. They dilate the airway, open up the airway. And this is true in people who have an overlap of diseases like COPD or bronchiectasis, or asthma and bronchiectasis, where an inhaled steroid and a bronchodilator together results in opening up the breathing passage and reduction of inflammation, and hence has a dual action on the breathing passage. But remember, this is not the majority. We'll hear Mikhail's opinion about the others.
Yeah, so for the majority of patients with bronchiectasis, there are other kinds of white blood cells or immune system cells that are called neutrophils, and this is the most common cause of inflammation in bronchiectasis. And for neutrophils, inhaled corticosteroids, unfortunately, are not effective. And we do have some drugs that are being developed. I think Amelia is planning to speak about this next. And there have been some trials of inhaled anti-inflammatory drugs in the past. Unfortunately, most of these trials were not successful. And it doesn't mean that the inhaled route is never going to be successful. It might be in the future. But the current anti-inflammatories that are being developed now are those that are used either by mouth or by intravenous or by injection. So I'll just stop here and leave room for more talk about anti-inflammatories.
Thank you. We have a question on the side effects of antibiotics and what patients can do to empower themselves around possible side effects. And one question was, should I be worried about hearing loss? And Amelia, I think you were going to talk about that, but then perhaps you and Rachel can talk about your experience of being told about treatments and being asked to weigh up what the risks of different treatments are.
Yeah, so just starting off on the hearing loss question. I mean, hearing loss is quite a common thing in general. So, over 50% of us, I think, over the age of 55 are likely to have some hearing impairment. So not everything is always related to the bronchiectasis, but it's important that you do discuss it with your doctor. There are some causes of bronchiectasis that are associated with hearing loss, like primary ciliary dyskinesia. So it's important you discuss it. And I assume that this question was related to hearing loss with a particular type of antibiotics, the aminoglycosides and azithromycin. So that is reported as a risk, and if you are prescribed these antibiotics and get tinnitus or hearing loss, then you should tell your doctor immediately. Now, it's a very low risk and it doesn't happen very often, but you should report it. And yeah, I think that opens up a wider conversation about risk versus benefit. My comment would be that many of these treatments have gone through a lot of research and approvals and regulatory procedures, and someone will have identified the benefit of taking them to be much higher than the risk of taking them. But it's also a personal choice, and the risk to different people may be different. I think it's a case of thinking about how likely something is to happen, and if something happens, what the impact would be on you, how severe the impact would be. So likelihood as well as severity, and that might be a personal choice. Rachel?
Yeah, it can seem scary, some of the information about side effects, and it can just seem scary, the concept of being on a lot of medication generally. But I think one of the easiest ways to feel empowered and to feel as if you are a little bit in control of what's going on is to just get into the habit of monitoring your body regularly anyway. So it's to kind of know what your own baseline is in terms of your lung health, what your own baseline is in terms of your gut health, your fatigue, or any other symptoms that you have, how easy it is to do exercise. It's really just to listen to your body, to take a little bit of time, a little bit of space, just to notice what your body is like normally, whether anything's changed. It's such a complicated system and everyone is different. So if you have a thing that you notice, it could be for so many reasons. It could be to do with your medication. It could be to do with changes in your disease. It could be to do with something completely different. It could, extremely likely that it's to do with stress. I think, I mean, and inflammation and stress, you know, I mean, a lot of things might just be to do with you're going through some period of stress and you haven't even really realized, but your body is telling you that in some way. So I think the more you get to know your body, you will know better than your doctor about your body and the way it reacts to things. You'll know better about dosages, about when to take medication, all of that. So I would say that that's your area of empowerment. And so if a treatment is suggested and you're not sure, I think try it and monitor it.
Thank you. We're getting quite short of time, so I think we might flip through the next questions quite quickly. One of them is on food, and in particular, does food like dairy make lungs sticky? And Mikhail is going to deal with that one.
Yeah, so that's quite a common notion, but it really doesn't have any holdings in research. So a lot of people here advise to stop dairy and to eliminate dairy from their diet because it brings up phlegm. And it's actually not true. People may see that their phlegm looks whitish after they drink milk, and it's probably because of the particles that end up in your phlegm when you have a little bit of reflux, which means food comes up to your, the other way around, to your esophagus and to your mouth. It's actually quite important to include a very mixed diet and have enough protein to have enough muscle mass. So it's really important to consult a dietitian before you start to make such drastic changes, such as eliminating dairy from your diet, and it's not recommended.
Thank you. And then on to a question, a really important question, which is about whether certain vaccinations are important for people with bronchiectasis. Raja, do you want to say something about that?
Yeah, so I think this is an important point, something which is very important to remember. So have your flu shots. The annual influenza vaccine is very important. It is important for a lot of comorbid conditions, chronic respiratory conditions, but also for bronchiectasis. You would want to get vaccinated for pneumonia, and that's not an annual vaccine. That's a vaccine that happens once in a lifetime with the newer versions that are available today. Then there's the Tdap vaccine, the tetanus diphtheria pertussis vaccine, for which So you've got that vaccinated with that in childhood, but even in adulthood, you would want boosters of the Tdap vaccine to happen on a 5 or a 10 yearly basis, depending on which part of the world you hail from and the local guidelines there are. Recently, there's the respiratory syncytial virus for which you need to get vaccinated against. And that's, again, something that's come into the adult vaccination guidelines. And that's another bug against which you need vaccination. The guidelines for getting vaccinated in COVID is variable across the world. So for us, there's no further COVID vaccine. There's some countries which still vaccinate people with chronic lung disease with COVID. So it's important to make sure that you speak to your doctor, ask about vaccination for the chronic lung disease you have. There'll be some variation amongst the countries where we live in, but it's important to remember that vaccines are important because they are preventive, and you need to have these shots because they prevent you from getting recurrent infections.
Thank you. And a question on exercise and what to do if you get breathless. Is exercise important? Should you still do sport? Arietta, would you like to say something about that?
Yeah, absolutely. And I'm very happy people ask this question because we overlook about it when we discuss about bronchiectasis, but exercise is actually important. So my advice is that you need to keep your physical activity and exercise. And we have evidence that people with bronchiectasis who attend pulmonary rehabilitation classes can reduce their dyspnea, so the breathlessness they feel. They can improve the quality of life in some studies, which is related to their cough, and they can also have a better exercise capacity, so they can do more things during their day without feeling breathless as much. So exercise is an integral part of the treatment of bronchiectasis, and we have good evidence to suggest that. If you don't have pulmonary rehabilitation classes in your area, you just need to try to gradually build up an exercise program in terms of doing more things during the day, and this will help you overcome this vicious cycle of inactivity, because the more sedate and inactive we are, the more difficult it is to do things, and we feel worse and more symptoms when we actually move. So exercise is absolutely a key part of the treatment for bronchiectasis.
Thank you. Rachel, do you want to add to that?
Yeah, just really quickly to say that for me, my airway clearance is about 1,000,000 times easier if I've just done some really, really strong, vigorous exercise beforehand. All kinds of exercise work. All kinds of exercise help a bit, but to be honest, the stronger, the more aerobic it is, the more it gets your heart rate going and gets you sweating, the more it really, really helps to get the mucus up. I think it's incredible. And so just anything you can do, exercise helps a lot for me.
Yes, and lots of people say that. So we have reports from many different people with bronchiectasis. The only thing I would add is that the exercise would not replace your former airway clearance, and we still don't have evidence that this can happen. So you need to use exercise alongside your airway clearance technique.
Thank you.
I also used sorry, just to say quickly, exercise helped me to notice, because before I even knew about airway clearance, I noticed that some kinds of exercise made me cough specifically, or specific types of exercise. And so if you do notice that something's making you cough, then I think you need to use that thing and then do your airway clearance immediately after doing that thing, whatever it is that makes you cough, because that's starting the process off.
Yes, good point. I agree. We'll move on to living with bronchiectasis and other conditions. And there's a question on what are the most effective ways of monitoring symptoms and lung health at home if we've got other conditions like aspergillosis? And are there any special treatment considerations that should be taken into account if you've got more than one condition like aspergillosis or NTM? Is there an order in which they should be treated? And we'll maybe start with Amelia for that, and then Raja's going to add something.
I'll maybe talk about the part of the question about monitoring symptoms and lung health at home. So I think sputum is important. So looking for changes in sputum, whether that's the volume that you're coughing up or the colour. If it tends to change colour, that can be an indication of an exacerbation. But also getting to know yourself and the general, how you feel. There's lots of options now for sort of keeping symptom diaries, like how breathless you are, and things like that, and a lot of that can be done on electronic devices as well, watches and phones and apps that you can track symptoms on, as a way of sort of thinking about how bronchiectasis is affecting you and what happens when things get worse and you're about to have a flare up.
Thank you. Roger, do you want to come in on that?
Yeah, so I'll sort of echo some of Amelia's thoughts. I think it's important to monitor your lung health in the way of symptoms. So you can do a logbook, you can do a spreadsheet and look for symptoms. So Amelia spoke about cough, sputum production, breathlessness. You could use a sort of visual scale or something that you can sort of put your breathlessness, cough, sputum production on. There are more general symptoms like fatigue, for instance, that you can monitor. Look at medication use, whether your medication use is becoming more, your rescue medication use is becoming more or not. In asthma, there is equipment which is called a peak flow meter, which helps to measure your lung function. Now, that's not something that is validated for use in bronchiectasis, but you could use it for yourself to see whether there's a sudden dip in your blowing capacity. So it's a small piece of equipment you blow into, and it could help you to know whether there's been a sudden dip in the levels. You could check your oxygen levels and make sure your oxygen levels are normal. You could do temperature checks if you're prone to getting fever when you get infections. So I think there's various ways in which you look at symptoms. I love the way Rachel spoke about patient empowerment. So I think if you have the knowledge and the understanding as to how you monitor your symptoms, you can actually decide the course of your disease. You can foretell when you might be getting a worsening of the symptoms and exacerbation of the disease process. And I think that's important. That is, in my book, something which is empowerment. As far as the order goes, I think there are managements of bronchiectasis across causes. So be it aspergillus, be it post-TB, be it primary ciliary dyskinesia, this treatment for bronchiectasis which needs to happen, the mucus clearance, the low-dose macrolides, or azithromycin, the nebulized antibiotics, all of these are for all varieties of bronchiectasis. And then you need to look long and hard for etiologies. You might have 2 or 3 different causes, and in some cases treating the cause, like in case of non-tuberculous mycobacteria, like in case of aspergillus, treating the cause also treats the bronchiectasis, and that's important to do. Hence, treatment of bronchiectasis, that's an overall umbrella. And then there's the question of treating the underlying cause, where there's a treatment available for the underlying cause. And I think that's important for us to remember.
Thank you very much. And then we've got a question about new treatments. Are there any new treatments for bronchiectasis that will be available for us? And Amelia, do you want to say something about that? And then I think Rachel's going to add something.
Yeah, so there's been a lot of studies of different treatments for bronchiectasis recently, and many of you will know about the class of treatments called DPP1 inhibitors. And this is a class of treatment that reduces essentially the neutrophils, or the neutrophilic inflammation, which is the white blood cells, and then the inflammation caused by the white blood cells. And when we do clinical trials, we tend to do a phase 1, a phase 2, and a phase 3. And if you have a positive phase 3 clinical trial, then those drugs will go to the regulatory authorities to be discussed for approval for use in clinics and treatment. So one of the DPP1 inhibitors, which reduces the number of exacerbations that people with bronchiectasis have in the trial overall by about a third, has had a positive phase 3 trial, which means it's now being discussed by the regulatory authorities. I think that's exciting. I think what's really important about that is that it tells us that if you treat this neutrophilic inflammation in bronchiectasis, then that can make a difference to exacerbations and flare-ups. And so there's a number of other trials and a number of other drugs now that are being tested that also target that neutrophilic inflammation, and they will go through a similar pathway of going through clinical trials. It also allows us to think about repurposing drugs that exist for other conditions. So there's some things available that might be for other conditions that we might be able to use for bronchiectasis. So there's also studies looking at that now that we know treating the inflammation can make a big difference. And then there's also drugs which are being tested at various stages in the laboratory and again in trials in patients looking to treat Pseudomonas and looking to treat Pseudomonas without the use of antibiotics. So it's quite an active time for the development of new treatments, and with some getting very close to being available to patients with bronchiectasis over the next couple of years. I would encourage anyone who is interested in helping with that and that being empowering in that way to ask your doctor if there's any trials going on in your local area, and if you're asked to take part, to seriously consider it. It gives you potentially access to those medications, but it also, is helpful for the entire community. And as I say, one drug getting to a point where it's nearly licensed actually makes a big difference to other drugs being developed as well.
Thank you. Rachel, do you want to add anything?
Yeah, just to add to the bit about clinical trials, yeah, it's my experience that your doctor won't know about that, and so that you'll have to ask. So really do ask. Just say, how do I find out? There's an NHS in the UK website you can just sign up to, and you can say, I have this condition. But your doctor will be able to find out about specific bronchiectasis trials, and if they don't know where to find out, they'll find out for you. So really do say it to them. And also, clinical trials are quite demanding. They're quite demanding on your time, and you might think it's too much to do, but do consider it, because they need people. They really need people to do it. And so you might have to devote, a lot of time to doing the thing that I said earlier, but in a much more formalized way, monitoring your condition every day for a long time. Do it, because it'll help you, and it'll also help loads of other people. I think it's hard for researchers to find people who will give the time to do it, so do. And then just back to the theme of empowerment. Also, I think some people get anxious because they think that they have a chronic condition and there is no cure and they're waiting for the cure. I think that's not a really helpful way to think of it, because there might not be a cure. I mean, we probably are not going to reverse the damage that's already in our lungs. We just might be able to make things better day to day with some of these drugs that are coming. And so rather than focusing on, but when am I going to have the magic pill? How long is it going to take? Is it in development or not? Just think about what you can do now, because there is a lot that you can do now. And a lot of it is just about making peace with the situation, rather than thinking, oh, my lungs are terrible, there's this terrible thing going on in my lungs. Just, this is the condition of my lungs. Other people have things with their other parts of their bodies that are not ideal. But, I make friends with it and I live with it, and I find out what I can do. So to try to be a bit more positive than you might be, because you think there is no cure. It's not as bad as that. It's not as simple as there is no cure. There's loads you can do.
Thank you very much. I totally agree. Now, the last question. Does anyone have one vital thing they would like to say to help people with bronchiectasis to take more control of their illness?
I'll go first.
Yes.
So educate yourself and ask questions. That's my one piece of advice.
Mine is do your airway clearance every day.
I think I'll go next then, because it's about airway clearance again. So try to find something that fits in your day, and you are fine to do it daily if you need to.
So from my side, the crucial thing is trying to prevent exacerbations. So all of what you've heard, knowing the disease well, understanding the disease well, doing the mucus clearance well, trying to find ways in which you identify or flare up of the disease early, all of those will go a long way in preventing progress of the disease. So do that, prevent exacerbations.
Yeah, and I'll follow up on that. Know to recognize exacerbations, know to seek treatment in time, and remember, or maybe even make a list of what has helped and what has not helped in the past in terms of antibiotics to treat exacerbations, but also increasing your airway clearance with exacerbations. So it's really important. You're the best knowledge of your condition.
Thank you all very, very much. And I hope that that has helped to empower many of you who are watching and who may watch later. I think time has run out on us, unfortunately, but there are plenty of sources of information online, which will be shown on the screen shortly. And so we hope you'll find that useful. And now I'm handing back to Jeanette.
Thanks, Bridget, and everybody. Well, I hope we have managed to answer many of your questions and that you've got some new ideas of how to take control of your condition. But see our slide for links where you can get more information after this event. A lot have been put in the chat already. So there's our information hub on the European Lung Foundation site. And if you missed our bronchiectasis patient conference earlier this year, you can catch up with the recording. It was a full day's event, so there's lots and lots of useful information there. And we have 2 new guides coming out soon, one about using nebulizers and another one about sputum, so do watch out for those. We've mentioned the Lung Foundation Australia Bronchiectasis Toolkit. And if you want to find out more about Embark and the research network, please visit their website. They have a new section on patient resources too. And there are also lots of ways you can get involved with raising awareness of bronchiectasis and helping to improve research and care. If you feel inspired, please do think about joining our bronchiectasis patient advisory group. You can share your experiences and collaborate with others living with bronchiectasis across Europe and work on projects with clinicians. You can find out more about the group on the website, or you can email us for more information. And if you want to get more involved in World Bronchiectasis Day activities today and in the coming days, there's a link on the screen about that. And do take the patient survey that we mentioned earlier. And finally, some final thank yous, especially to our bronchiectasis experts, Rachel, Mikhail, Raja, Amelia and Darietta. Thank you so much for sharing all your expertise with us. And to Peter, who has been really busy answering the questions in the Q&A, thank you. And Bridget, thank you for hosting and managing the discussion so well. And finally, thanks to the Embark Steering Committee, the ELF Bronchiectasis Patient Advisory Group for their support. And most of all, to everyone who's joined us today, thank you so much. And we hope you found some really useful tips. So have a great rest of the day and hope to see you soon. Thank you.
Thank you.
Thank you.
Thank you, everyone. Bye-bye.